Good evening. Thank you all so much for coming and for sharing your precious evening with us. I thank you very much for that. We are streaming this live, and that's why I'm starting somewhat more timely fashion, because there are people, we believe, watching online. A little bit of housekeeping. You see cards up front and in the back as well that have a method for you to submit questions online. We're going to try something new and see if we can take questions online, as well as a microphone in the middle if you want to come to the microphone. And if you just can't stand to do any of that and yell out your question, I'll repeat it for the sake of the recording and for the sake of the online people. But again, thank you very much for coming. I'm going to make a few remarks, maybe 10, 15 minutes, and then the time is yours, because I want to hear questions, concerns, comments, begin to sort of triangulate and understand where you are with the changes that are happening, let you know where I am, see if we can head off in the same direction together. You have heard regents, the chancellor, and others use the word momentous and historic for what's happened in the last couple of years, and certainly what's happened in the last several months. And I think those words are appropriate. I think that what is happening to this school, what is happening to public medical education in Nevada is momentous and is indeed historic. I actually think that this time will be remembered for decades. I think that we will remember this just like the history talks about the formation of the school in the late 60s and the legislative process and the bargaining that took place and the decisions that took place that launched the school at that time. I think this is equally big, and perhaps bigger in certain regards, because the stakes, I think, are so much higher. Where we are now is the result of the work by lots of people over the past 2 years, roughly. This process was led by the chancellor, led by the Health Sciences Committee and the Board of Regents. The result of that is I think we have a clear vision for where this school is going, where public medical education is going. I think a lot of the institutional tensions, the political tensions, the economic tensions have been resolved, not completely and not never, but I think to a considerable extent, much of what many of you have experienced over many years, and some of you over many, many years of difficulties, I think much of that is beginning to fade. What we're seeing is the creation of one medical school in Las Vegas and the recreation or the rebirth or the restructuring or the renewal. We've tossed around lots of words along those lines, but an entirely reformulation, shall we say, of this medical school. And that's what I want to focus on to a considerable extent. I actually think that this is sort of normal in the sense that this is what academic medicine is all about. This is how it evolves. This is how it grows. This is how it develops. And so what we believe to be quite momentous and historic, in fact, has happened in various ways for different schools in different states over time. I'm not sure anything quite like this has happened. I think this may actually be quite unique in the history of medical education. I think that the most momentous part of this, in addition to the actual decisions that have been made, is the elimination of one critical piece of uncertainty, and that is whether the state is behind the medical school, whether the Nevada system of higher education is behind the medical school, whether the Board of Regents is behind the medical school. I think the answer to all those questions is yes. And I think you have not lived with that for some time, perhaps, that there has been great anxiety about whether the state really cares about the school, whether the regents really care about the school. And I think the answer is resoundingly yes. So there are many other uncertainties, many other implementation issues, many other things that we'll talk about. But the fundamental issue is that we now have a very clear charge, a very clear mission, a very clear vision that is accepted statewide. And I would not underestimate the importance of that. The tasks for UNSOM and for UNLV are very different, but equally demanding. And I would not underestimate that as well. For a lot of reasons, most of the attention, most of the energy, most of the media coverage has been on UNLV and on a new school of medicine. That's perfectly fine and perfectly appropriate. There is an equal intensity to what UNSAM has to do. Different tasks, which I'll talk about a little bit, but very equal intensity. This is way more than just, let's build a few clerkships in Reno and kind of finish off the school. Way bigger than that. So what I think we have to do is to go through a new understanding of that, a new understanding of the mission, a new understanding of the vision. What are we about really? What is our role in the state? Up until this point, the school has been defined by geography, which is a pretty poor way to define a major enterprise in medical education. If you go on Google and you just put in the question, what is the point halfway between Reno and Las Vegas, the answer is Millers, Nevada, which is a ghost town. And you can put whatever symbolism you want with that, but that has to some extent defined us, which is how are we sort of not anywhere exactly and everywhere and serving not just Reno and Las Vegas, but rural communities as well. And I think that has been resolved to some extent. We clearly have a new geographic center, and the geographic center is Reno. Not to say that our other constituents are not equally important because we have a statewide vision, we have a statewide purview, but I think we're very clear about where we are based. It all comes back to our core missions, and you're going to hear that a couple times in my comments. Fundamentally, we have to focus on what it is we are about. What is our fundamental purpose? Patient care, teaching, research, service to the state. There are trite phrases that come to play here. Change equals crisis and opportunity. This is the first day of the rest of our lives. There are others. But it is absolutely clear that there are wrenching changes coming, major changes coming, and major opportunities coming. And if we remember what our fundamental purpose is, I think that those will play out. But I do think it may require a rededication to those purposes. I think that because of what's gone on over the last many years, that we sometimes forget those fundamental missions, those fundamental values for the sake of survival and the many difficulties that the school has gone through. What I'm going to focus on a bit is all of us identifying with a much larger purpose in a much larger institution. And an institution that has momentum, and an institution that has identity, and an institution that has maturity, and an institution that has vision, and an institution that has mission. And begin to think about that identification, that this is much bigger than all of us. So I'm going to address a couple of questions. First is, what do these changes mean for UNSAM? Second is, what do they mean for you? Third is, what do they mean for me? As I have said in some of these sessions in the past, my job is not necessarily, although it would be nice, but my job is not to necessarily make you happy about your particular situation. Because it's impossible, number one. But number two, everyone has to find their place in this organization and find their place in this institution and find their place in this vision that we have for this medical school. So what I want to do is to validate for you what's happening, maybe explain a bit about what's happening, provide some larger perspective, put this in some larger perspective, accept the reality of what's taking place, some of which is not in our control, talk about the inevitability of change, and keep the focus on our fundamental purpose. So let me start with a legislative update, just so you know kind of the basics of what has happened over the last few weeks, culmination of what has been described by the Chancellor again as a historic legislative session, in everyone's memory, the best legislative session that can be recalled. And it's because of the state's willingness to invest. And like all of legislation, it was a messy process, but it ended up with a remarkably good outcome. So UNLV received the full appropriation requested by the Nevada System of Higher Education. Their intent is to file their application this summer, as I understand it. and to be site visited sometime early mid-16, to receive approval to accept students in the fall of 16 and to admit students in 17. It's an extremely fast time frame, not impossible. There probably are glitches that could come up along the way, but I think they're fully committed to doing this, and I think they have every intent of doing that. What didn't get so much attention is that we received our full appropriation, which was submitted by the higher education system to the governor, then modified, then restored, and finally came together with the full legislative appropriation. The total is about $5.5 million. Starts out small in the first year, then ramps up in the second year. So all of what we're going to do with this is going to take place over the next 2 years. It supports a host of new activities related to an Office of Community Faculty that will reach out to community physicians and provide all of the support, the faculty development, the paperwork, the scheduling, the training, the troubleshooting for them to serve as faculty members and teachers in the medical school for clinical clerkships. Other ways that we're going to support community physicians and expand clerkships, clerkship coordinators, other infrastructure that goes with that. Increased staffing for the Office of Academic Affairs to support this whole new set of teaching missions, support for our LCME process, our accreditation process, which will start ramping up big time this coming fall, hit real hard and heavy in 2016, site visit in the fall of 17. So we have our own LCME process playing out, which has not received much attention to this point. We have one-time funding for Project ECHO. Over the next couple of years, we have funding for matching funds for loan repayment, which we have not had for a long time, so there will be new opportunities to support medical students. There is some one-time funding from another tax source, $3 million, that will help support the purchase of surgical simulation training equipment in the Simulation Center in Las Vegas. We'll support build-out of the LEAD Clinic, which is the new pediatric clinic for underserved kids in Las Vegas. We'll provide support for the new 1701 building in Las Vegas. That money was totally committed or had to be totally committed to Las Vegas purposes. But separate from that, from the funding, from some of the specifics, what the legislature really did was to say, we are prepared to invest in and support 2 full medical schools, which again, I believe is an historic event. It creates something that the state has never seen. 2 schools, different communities, different missions, probably competitive in certain regards. I have no doubt that there will be competition for students. There'll be competition for funds down the road. There'll be other ways that this will come up. But I also think the schools can be highly collaborative and that there are research collaborations and educational collaborations and other things that can be done that can be very positive. But that's ultimately what's important about the legislative session. I would also note, just as an aside, that the legislature did other good things that affect higher education in general. Eliminated furloughs, added cost of living adjustment to state funds, so people who are funded on state support, all or in part, will receive those adjustments. And there's another fund, separate fund for GME support that will support startup of new residency programs. So by any measure, those are extraordinary commitments by the state. Let me talk specifically about Reno. I'm going to talk specifically about Las Vegas, in Las Vegas, and then come back together and talk about what this means for the school as a whole. So what it means here is, in a sense, kind of a back to the future, in a sense that in the 80s into the 90s, the school was fully based here. And there was rural outreach, connections to community physicians, connections to local hospitals. School was small, but had its place in Reno. And then went off and became sort of far-flung to Las Vegas and other points, and now it's coming back in a sense. So above all else, what's going to happen here is a full school, full campus, full 4 years, a full medical school, just like any medical school you would see anywhere. We've not seen that for a long time. Hidden in that are other issues, it resolves what I think was inappropriate labeling, kind of a pigeonholing, in which Reno was viewed as, well, that's the basic science campus and the basic science teaching and the lecture halls and the labs. And then Las Vegas was the clinical campus, clinical practice, clinical teaching. In fact, there was a bit of crossover over all this time that was hard to do, hard to develop. Collaboration was difficult, but there was a bit of a sense of crossover, but we still got labeled inappropriately, which also was an extraordinary hardship on students. And I'll just mention what I have in other settings. We way underappreciated how hard this was on students, and the difficulty of coming to Reno for 2 years, moving at least in part to Las Vegas for a considerable part of the 3rd and 4th years. Impacts on spouses, kids, homes, jobs, lots of difficulties. Being here is more than just quantitative change. It's more than just saying, well, we're just going to take some pieces that are here and we're just going to move them over here. There's a huge qualitative difference in having that integration. Medical schools are ultimately some of the most highly integrated institutions with clinical platforms upon which teaching missions are layered, upon which research missions are layered. And the opportunity to do that in one community is extraordinary. And the inability to do that in one community for all these years has been a huge problem. So I think that there's much more to this than just saying, well, we're going to have a school. Now we have the ability to actually create that entire integrated clinical and academic system that we would want. This involves many partnerships. And again, partnerships that were not impossible, but were really difficult when we were fragmented, as we were to this point. So partnerships between the school and hospitals and healthcare systems in the area. Partnerships between basic science and clinical science, which is very exciting to me in terms of potential research collaborations. Partnerships between medicine and other health professions. Having more clinical students here has huge potential for interprofessional teaching with our other health professions disciplines who have clinical students here as well. Partnerships between the school and community physicians I've already talked about. Partnerships between the school and UNR. UNR itself has not fully seen what it means to have the full medical school in Reno. And to talk about a medical school is fine, except that most of UNR hasn't seen half of it. We know it's there. We know what it means to go back and forth. A lot of UNR doesn't really understand what it means to have the 3rd and 4th years, and then the linkage to new GME programs as well. A lot of this is a public-private partnership arrangement that I'll comment on in a second, because I think it's a bit new for us in part. The consequence of all this is much more demand on our leadership structure, much more demand on department chairs, much more demand on a more extended dean's office leadership structure. This is a way more complex medical school than people remember from the past or we have seen up until recently. This is not just a small community-based school with some nice buildings in Reno and some clerkships in Las Vegas. It is way more complicated than that, and it requires way more commitment by everybody in this room, but particularly those with formal leadership responsibilities. Let me comment now on the public-private issue. This is something you're going to hear more about. We are a community-based school. We do not own our own health system. We do not own our clinical platform. We do not own 2,400 full-time faculty members like you might see in some major integrated systems. So we need partnerships, and we need to understand how to create those partnerships. Let me comment very specifically on one that's very exciting to me, and that's the new affiliation agreement with Aurora Diagnostics. You've not heard much about this. It's going to be coming out with more media coverage, more press release. This is a national private diagnostic pathology company of extremely high quality that has a major operation in Las Vegas, a smaller operation in Reno, and we have just completed agreement to integrate and to merge and assimilate those two operations. The net result of which is we now have a Department of Pathology that will be 6 or 7 full-time faculty members and 35 adjunct faculty members of all subspecialties, very elite group with very high levels of training to serve on our faculty for teaching purposes, to serve as consultants. And one benefit is we now have a new chair of pathology, Dr. Marcus Erling. Marcus, raise your hand. Okay. Who has joined the school, a former medical student here himself, who will bring that connection to this partnership between the clinical platform of Aurora and the faculty members who are now the pathologists from the school and from Aurora, who have come together as a single department of pathology for academic purposes. The types of collaborations that can come from that, not just teaching, but research collaborations, the possibility of Dr. Erling and his group collaborating with basic science departments and providing tissue specimens, access to tissue samples, the types of molecular pathology and anatomic pathology research that can come from that is something that we have not seen in that department. That's extraordinarily exciting, but it takes that kind of partnership to make that happen. We'll have partnerships with major physician groups in Reno who are coming forth with great enthusiasm to partner with us. We're developing a family medicine residency program at St. Mary's. Now, there are discussions about these partnerships that they're somehow exposing us to some vulnerability, that we don't have control over our destiny. That's right, we don't. We need these partnerships structured properly, the right legal arrangements, the right financial arrangements, to have the system that we need to be successful. I think that one point I want to get across is that the issue of known versus unknown risks, the risk of the status quo, the risk of not reaching out, not creating these relationships, not exploring these partnerships, the risk of not doing that is way greater than the risk of doing it. And accepting the status quo and thinking of ourselves in fairly confined ways, I think will not make us the school that we want to be. Let me talk about Renown. That's obviously the huge partnership and the one upon which the entire school's future, I think, rests. This partnership has come along with a year and a half of very intense discussions. And you've heard about a considerable amount of it in press releases and announcements. The point I want to make about it is that it's not about the personalities. It's not about me. It's not about the new CEO, Dr. Slonim. It's not about Dr. Piasecki or Dr. Kopis, who are the executive officers who are exploring the implementation of this. It's not about specific board members. This partnership transcends all of that. This is the highest level of community importance, and it's being scrutinized at the highest level by the community and being monitored by the community and is accountable to the community. So I want you to understand how high level this is. This is not just because some of us happen to get along when we didn't get along in past personalities or past leaders, and therefore it's susceptible to change as people wander away. It's way bigger than that. And there are many pieces to this. The clinical integration of pediatrics and internal medicine that we're exploring. Why are we doing that? It's because our relatively small departments of medicine and pediatrics can't come close to being the clinical platform that we need for those disciplines. By joining forces with an integrated health system, those physicians, those departments have huge value as primary care providers. By themselves, it's very hard to have the capital, to have the investment, to have the ability to be what they would want to be. As part of an integrated health system, they can really flourish. We are recruiting a new chair of pediatrics who will also be the pediatrician in chief. That is progressing extremely well under Jennifer Hagen's leadership. And I hope that we'll close on that and have announcements relatively soon. We've had outstanding candidates. Dr. Slonim is talking about a Northern Nevada pediatric ACO, one of the very few pediatric ACOs, accountable care organizations in the country. This would be monumental in terms of a complete region committing itself to improving the care of children and for the school to be a major part of that. We're talking about a pediatric residency program. We're talking about a child health services research unit that Renown is funding at the School of Community Health Sciences with Trudy Larson. We're talking about the Department of Neurology. The Institute of Neurosciences at Renown is now going to come across and be our Department of Neurology. Dr. Lopez will be the interim leader of that for Renown and also our interim chair, and we will capitalize on what was approved by the regents last year. The Office of Community Faculty, you've already heard about, will be the academic partner for Renown in terms of their IRB and their grants administration and their library support and their CME. Those are the kinds of things that we can be as a partner to Renown. We're talking about new approaches to faculty tracks, faculty titles, how community physicians are enfranchised and become part of the school. And there are 10 other major initiatives that go with that. So that's just a sampling of what that kind of partnership means. Okay, let me close it down and talk about those final questions. What does it mean for UNSOM? Not just Reno, but for Las Vegas and Reno. What it means is we are now responsible to the state. The state cares what we do. The state will pay attention to what we do. We are accountable to the state for our performance, for our service to the state. The Nevada System of Higher Education, the Board of Regents, I think, are committed to our success. They're committed to hearing regular reports. They're committed to monitoring how we interact with UNLV, how I interact with Dr. Atkinson, the dean there. People care, and people are going to pay attention. And we are, I think, accountable to the state for how we serve the state and how we contribute to the quality of life. The strategic planning phase that occurred to this point is now going to enter a very intense implementation phase. And we're going to be at this for a long time. This will be defining for the school for the foreseeable future. I think you'll see a lot of collaborative planning with UNLV. I'm sure there will be moments of conflict and difficulty, but we've already seen a collaboration. UNLV reached out to some of our faculty members, including Dr. Palmer, who's here, to serve on their LCME planning committees. I think that's a very positive sign that we can contribute to their success with the LCME. In Las Vegas, I think you'll start to see faculty recruitment by UNLV, not this coming year, but probably the year after. That's what I understand from Dr. Atkinson. You'll see clinical integration take place here over the next several months. You'll see more medical students in Reno as soon as this fall. You'll see a big up ramp of medical students by the following year, and I think by 17, certainly by 18, but mostly by 17, you'll see the full complement of medical students here. You'll see new clerkships here. You'll see a host of new community physicians engaged as faculty members. You'll see hopefully a neurology residency program start to ramp up by next year or the year after. Pediatric residency will be in process. A host of research collaborations. A lot will happen. What does this mean for you? Extraordinary options and opportunities. Fundamentally, the faculty and staff of the school is our capital. It is our most precious resource. And our task basically is to link you as that resource to our school's mission, to our school's vision. That took a certain form in past years, took a certain form to this point, got beat up along the way by some political and economic issues. Now I think we actually have a chance to think about how people resources get linked to institutional missions. I think in Las Vegas, what's going to be tested is their fundamental commitment to academic medicine. I think that there is always this sense of, well, it just looks like there are bad things happening and the school is shifting away from Las Vegas. I can just go into practice. And that's the phrase I hear sometimes. I think this is going to really test how committed is our faculty in Las Vegas to being part of academic medicine. Here, I think that the test is your commitment the Reno faculty and staff's commitment to partnerships, to the community. We do not have the luxury of being isolated in an academic way. We have to get out, we have to be in the community. There's going to be incredible amount of expectation for us to contribute, to be a major driver of quality healthcare in northern Nevada, and to be the school that we were meant to be. What does it mean for me? So I hear all kinds of rumors. People think that because somehow I'm not the statewide dean anymore, that means I'm going to leave. People think that this is now the end. I've done what I'm going to do, and it's time to move on to what? I have no idea. I cannot be more clear that I am so energized about this. I'm so committed to this. As far as I'm concerned, the last 4 years has been work to get us to the starting line. This, to me, is the whole point of being here. And when people in Michigan 4 years ago told me I was a complete idiot to come here, I said, no, I think good things can happen. And I think this is what's happening. This is the point. This is why I thought there were great things that could happen here. And so I am, for better or worse, as you choose to see it, I'm not going anywhere. At least I'm coming into my 5th year review, and we'll wait to see what the president has to say about that. I guess what I want to leave you with is that this is way bigger than all of us. This is more important than any of us. It is so much more clear now where the school is going and what we're doing. We have so many constituents now that depend on us. Students, patients, residents. Science depends on us. The opportunities for research collaboration are huge. Business depends on us. Employers depend on us. The healthcare of the entire system depends on us. This is not totally about us needing others. Others need us. And I think you need to get that point, that we have things that people need, and we have things that people want. And we're not coming into this in a disadvantaged position, that we have a lot that we bring to the table here. And I'll just finish by saying I think now is the chance to be the school that we were meant to be. So look for more communications. Nevada Medicine Weekly. Other social media is out there. Lots of updates on websites. State of the School address is coming up in September. This is going to be constantly changing, constantly moving, lots of new things every week, and you're going to hear about it every week. So with that, I think it's time to hear from you. So you've seen the website, you see the microphone, you can yell, and we'll hear from you. I don't know if I'm connected, Jessica, but I'm not seeing anything at the moment, so let's see here. Yeah. Let me try it again. So a question here, how will we distinguish UNSOM from UNLV School of Medicine in recruitment and retention of high-quality faculty and students? What is our message going to be? Great question. I should call on Susan Hill for that. I think that, to some extent, is what we are going to do from this point out, which is to begin to actually ask that question. We didn't have to ask that question before. We were just the state school. What were we? We were the state school. And there wasn't a choice, and so we didn't think so much about that. We liked the class size, we liked the small faculty-student relationships that were so intense. We had a very strong basic science research. We served the state. You know, those were some of the buzzwords. If I were to start to think about a phrase, I would think about things like research intensive, and not just basic science research, although that's the platform. I'd like to see scholarship for all medical students. That could range from basic science research to community needs assessments, to health services research, to working in the community with the School of Community Health Sciences, to educational studies and educational development. So I'd like to see scholarship built into that for medical students. I think the potential for building a clinical and translational research infrastructure on top of our basic science infrastructure is huge. I think we will always be very primary care oriented because those are our roots in Reno. I think the outreach to the rural communities is very important. I think we will probably, at least for the foreseeable future, always have that more than UNLV, at least for the moment, because they're going to be very much more urban intensive and urban underserved care. So those are the kinds of phrases that would come to me. I think that the faculty commitments to students, the incredible bonding that takes place that you see every year at graduation, I think that is a plus that we would talk about. The students rate the school at the highest levels of value for the entire country. If you look at nationwide surveys of all medical schools, we are nearly at the very top, rated by students in terms of value of the medical education and the quality of the medical education. So those are the things that come to me. The phrase research intensive and primary care oriented, to me, especially as a family doctor, is a great phrase and speaks to, I think, a way to really position ourselves. This is a very unique school, and you all probably don't totally get that. We are the most research intensive of the community-based schools and the most community-based of the research schools. So we're right at the intersection. It's a very interesting intersection. And I think it's a good place to be. And I think we can even be more of that as we get into more clinical and translational research, which I think we can develop the support to expand. Pediatrics will be a huge platform from which to do that, but I think it can be more than that. So those are the words that come to mind right now. I think if you listen to Dr. Atkinson and the kinds of things they talk about, they're talking about much more specialty orientation, much more urban underserved care. They're going to explore some different curriculum models. They're doing some things that are more specific to a large urban area, and especially with what will be an increasing partnership at UMC as we back out of that a little bit. We will have a huge role in Las Vegas with Mountain View Hospital and our residency relationships there, and continued student exposure to UMC on more of a selective basis. So we'll still have a major presence there, and that's part of our statewide vision. But in terms of how we position ourselves here, I appreciate the question. I think it's a great question. I think there are some answers to it. What else? So if there are questions coming from home, they would show up here, Jessica? Okay. Dr. Buxton.
Dean Schwank, in order to have a more complete campus in Reno, one imagines we need to train students in surgery and OBGYN. Could you comment on those plans?
Yes, I can do that. We have plans to place students in a new surgery clerkship as soon as this fall with a very exciting collaboration that came together. It's a great example of how the school can be a catalyst. So Western Surgical, the major group in town, and two other surgical groups that to some extent competed and to some extent squabbled about emergency room coverage and acute care surgery coverage and ICU coverage, came together under the facilitation of Renown to form a hospital-centered acute care surgery, surgical ICU, trauma service to which all surgeons contribute. And half of the purpose and half of the motivation for that was to cause that to be the platform in which the clerkship will be based. This is going to be a surgical clerkship that I believe will be amongst the best in the country. And the reason is because it was purposely designed for the clerkship to be layered onto this new service that involves surgical diagnosis, surgical therapies, postoperative care, pre-op diagnosis, ICU management, fluids management, acute care issues that are the core of a surgery clerkship. Would it be sufficient for a surgery residency? No, not even remote. But that's not the point. The point is it's very specific to clerkship teaching, very specific to our student teaching needs. So you're going to see students doing that as soon as this fall. Is that right, Tim? Yeah. And right behind that, OB-GYN is coming with the major OB-GYN group in town and other collaborators starting to lay out the pieces for a major labor and delivery experience, an inpatient GYN surgery experience, and now we're exploring an outpatient GYN surgery experience that might involve the creation of an actual teaching clinic with all of these community physicians contributing to the creation of a clinic purposely designed for the teaching of medical students, with also providing service to perhaps underserved patients who may not have access elsewhere. And that may happen, at least on a preliminary basis, as soon as this fall or on into this coming year. So there's a lot taking place there. Are those typical academic departments of surgery? No. Are they really innovative, really creative, really dedicated teaching services? Absolutely, which is our fundamental purpose. So I think it's an example of how you don't have to have the traditional structure to have to meet missions in certain ways. And it gets to a secondary issue, if I can digress a bit, which is the issue of the practice plan. The practice plan is obviously going to go through major changes. Pediatrics and medicine are going to become more renown-centric in terms of their clinical operations. At the same time that we add the geriatric services at the Sanford Center, we add the mental health services from Mojave. Psychiatry is going out to establish a whole new outpatient set of services that they have not had previously. So the practice plan is going to look radically different. I'm going to embark on an educational initiative with the regents at their request to some extent, which is good, and start to educate them about practice plans. But I think that may be helpful to all of you and to others as well. There are as many constructs of practice plans as there are medical schools. And that's because practice plans are not ends unto themselves. They're a means to an end. They are a clinical platform to achieve academic missions. So they can look in all kinds of ways. You can have totally separate private practices in which physician faculty members actually receive a separate check from their practice, and then a check from the medical school. You can have hospital-based practice plan, completely hospital-based. We could take our entire practice plan and make it renown-based, for example. There are schools like that. Every other version that you could imagine. They do not have any intrinsic value. They are only valuable to the extent they support our teaching mission, our research mission, our academic mission. So I think that there are reasons why our thoughts about what a practice plan should look like will change over time. And again, the point is, how do we achieve our fundamental missions? We do have fundamental academic obligations. How do we go about doing that? And I think there are different ways to do that. I have more questions here now. Please comment about a plan for Las Vegas-based faculty members. What support will be provided if when their positions are gone in 2 years? I don't see that happening. I don't think that's how it plays out. I think that there will be joint appointments. There will be funding from UNLV for a large number of Las Vegas faculty members. I think there will be departments forming at UNLV that will provide opportunities. There are teaching opportunities at Mountain View that are forming that will still involve UNSOM faculty appointments. If you look at the funding for the Las Vegas faculty, heavy clinical support, heavy support for residency training, that comes from UMC by and large. That's going to continue either through us or through UNLV. I think that the support we provide for residency training may end up coming from UNLV. There's some student teaching support. There'll always be some students there. Does that mean every single person will have a complete mapping of their current funding to their future funding? Probably not, but I think that there are enormous mixes and matches of opportunities, and I'm going to say the exact same thing in 2 nights in Las Vegas. Will we be known as UNSOM or UNR UNSOM at some point? Great question. So I spent about 3.5 years purposely going out of my way to never say the UNR School of Medicine and to correct people who did say the UNR School of Medicine. Now you will notice that everybody talks about the UNR School of Medicine, and nothing bad happens when we say that. And I think it's inevitable that will happen at some point. I don't think there's any big rush, and you do have to remember the statewide purview, the statewide vision. We still will always have significant rural commitments, significant Las Vegas partnerships. And so if people are comfortable with a UNR School of Medicine, I think that's perfectly fine. But I would say, as I go around and talk to people, people are pretty attached to the University of Nevada School of Medicine name, and I don't think there's any problem with that. There's not that much pressure from Las Vegas anymore to get rid of that name and to push back to the UNR School of Medicine. Las Vegas is really enthused about UNLV, and there's not so much tension around that issue. People are happy with what we're doing. People are happy with what UNLV is doing. So we'll see how it plays out. I think these things sort of answer themselves over time. I think they just take care of themselves. When it seems like it's natural, when it seems like that's the way everybody thinks about the school, that will be the time. Will it come? Yeah, probably at some point. It's hard to say. Do I think the renowned partnership will be a differentiator, giving students the opportunity to experience, see, and do more than they might in other communities where it might be more difficult to obtain these experiences? I'm not so sure it's an either-or issue as it just leavens the mix so much more. Now, this is a very high-quality health system. They have quality initiatives, patient safety initiatives, clinical practice guidelines, service lines, quality standards, other initiatives that we couldn't possibly create in our practice plan, do not have the capital to support that, and have not found to this point in our major partner, which is UMC. UMC is enormously valuable for teaching purposes because of the pathology that's there, but it's, to be pretty blunt, they do not have some of the resources and some of the initiatives that one might find in a hospital like Renown. So there's fabulous complementarity to this. I think what students will see is a very high quality of clinical practice. And from here on out, I think with Dr. Sloan and Dr. Kopos, I think you're going to see even a more innovative and creative approach to quality and safety in medical practice. There's going to be integration that we've not seen before in terms of community-based care, community outreach, ways to keep people out of the hospital, ways to reduce readmission. The stated intent of Dr. Sloan is for the hospital to not be the center of care anymore, that we need to think outside, think outwards towards the community and how care gets delivered in the community. And those are the experiences that our students need to see. Do they need to see incredibly complicated, incredibly sick, underserved patients at UMC? Absolutely. Do they need to see the highest quality of quality initiatives and patient safety and other programs at Renown? Absolutely, because that's the direction of the healthcare system as well. If I keep scrolling, will I see things here, or is that it? I think that's it. What else would you like to hear? All right, so this is the start. You'll hear much more. I want to at least get some of this out so you understand where we're headed. There certainly will be follow-up at the State of the School address. Please let me know your thoughts. Thank you very much for coming.